The next paper is comparison of initial and redo paraesophageal hernia repairs, and it's going to be presented by Dr. Wintergren from University of Kentucky.
Thank you, and good afternoon. Thank you for the opportunity again to speak with you this afternoon about our findings in regards to outcomes in comparing redo paraesophageal hernia repairs as compared to those undergoing initial repairs. Is this how you? Sorry, how do you adjust this thing here? Okay, thank you. Sorry. So I have no disclosures to disclose. As by way of introduction, an estimated 15% of patients are thought to harbor hiatal hernias, although the majority of these do not require intervention, usually reserved for patients with large paraesophageal hernias or those that are symptomatic, have associated gastroesophageal reflux disease, refractory medications, or those with stigmata of reflux disease, such as Barrett's esophagus, peptic strictures, or those with extraesophageal manifestations of reflux disease. Reoperative rates in these patients having a history of undergoing a previous repair for paraesophageal hernias reportedly has been on the order of 5 to 10%, but can be as high as 30%. And in those patients who have had a previous repair and had failure of their repairs, 50 to 75% of the time, a recurrent hiatal hernia can be attributed to this cause. Therefore, redo paraesophageal hernia repairs are uncommonly performed for recurrent hiatal hernias, and as such, there's little understanding as to the perioperative outcomes in these patients, in addition to subjective patient variables. Therefore, the objective of our study was twofold. First, to evaluate perioperative outcomes in patients undergoing redo paraesophageal hernia repairs compared to those undergoing initial repairs, as well as evaluating patients for subjective variables, such as patient satisfaction and overall symptomatology. After obtaining institutional review board approval, a retrospective review from a single institution over a 4-year period was conducted of data identifying patients, all patients undergoing paraesophageal hernia repairs at this institution, and analyzing the data for patient demographics, operative details, and perioperative outcomes. In addition, a 2-to-1 match cohort was selected randomly from the patients of the groups identified as having undergone initial repairs to be selected as a match cohort. In addition, a 15-item questionnaire was also administered to the patients in the redo paraesophageal hernia groups, focusing on persistence and degree of symptomatology in these patients on a 10-point scale, and also overall satisfaction with the surgery on a 5-point scale. Statistics involved or employed were Fisher's exact or chi-square tests, as well as t-tests and Mann-Whitney U-tests were appropriate. In all, we identified 336 patients who had undergone paraesophageal hernia repairs during this 4-year time period, 40 of which had had a history of prior paraesophageal hernia repair. And of them, 6 were excluded for the following reasons. 3 had undergone subtotal gastrectomy with Roux-en-Y reconstruction, 1 undergoing a total gastrectomy with Roux-en-Y reconstruction, and 2 undergoing pyloroplasty. Therefore, it left us with 34 patients having been identified as undergoing a prior repair or otherwise redo paraesophageal hernia repair for the first time. And again, 76 other patients were randomly selected to act as a control group, having been identified as undergoing initial paraesophageal hernia repairs. Data collected was variable, obviously including patient demographics, perioperative outcomes, as defined here in this figure. Initial comparisons in terms of patient demographics between both groups was not statistically significant. When comparing initials to redo paraesophageal hernia repairs, there was no statistical significance difference in terms of Demeester score, Barrett's esophagus, gastritis. Mean length of stay for both groups was, on average, 2 days, with a range of 1 to 3 days. And readmission rates was 15% in the initial group, as opposed to 24% in the redo group, although this, again, did not achieve statistical significance. When comparing, again, initials to redos, there was a difference in terms of operative times, with a mean operative time of 163 minutes in the initial group as opposed to 203 minutes in the redo. Collis Gastroplasty was also more commonly employed in the redo group, almost 25% of the time as opposed to only 1% of the time in the initial cohort. Gastrostomy tube placement was also more frequently employed in the redo group, 29% of the time as opposed to 11% of the time in the initial group. And estimated blood loss, is that defined by a blood loss greater than 10 mLs, was seen in just over 50% of patients undergoing redo paraesophageal hernia repairs as opposed to only 25% of the time in those undergoing initials. There were no leaks identified in this series, either intraoperatively or postoperatively, and there were no deaths to report. Median follow-up time was 269 days in the redo group with a range of 23 to 1,782 days, which is just about under 5 years, versus 120 days in the initial group with a range of 3 days to 1,519 days. 48% of patients in the redo paraesophageal hernia cohort participated in the questionnaire survey, with almost 2/3 of them complaining of bloating, followed by nausea and vomiting, with a tie at third place with a combination of chest pain, dysphagia to solids, and reflux disease. And in fourth place, distant fourth place, at 19% was hoarseness. However, despite every single patient in this cohort who participated in the survey having symptomatology to some degree, 88% of them overall were satisfied with their surgery, with all of them but 2 rating their satisfaction a number 5 on a 5-point scale, with 1 rating it a number 4 and another rating it a number 1. Therefore, in conclusion, redo paraesophageal hernia repairs are performed with similar outcomes when compared to initial repairs, with the exception of increased operative times and estimated blood loss. They are also more likely to require Collis Gastroplasty. And although patients remain symptomatic postoperatively, overall their satisfaction remains high. Thank you very much.
Paper is open for discussion. If not, I have a question. You know, just looking at your data, you have 38% of reflux after the operation. And I know this is a subjective, data from the patient. Can you elaborate a little bit about the objective measurement? Is the patient getting EGD or 24-hour pH after the operation? And
no, this was strictly just the post-op questionnaire, and this was, and as I said, the range was almost 5 years post-op from these patients' initial redo paraesophageal hernia repairs. So we did not have any any objective variables such as endoscopy or pH studies.
Any other questions? Okay.
John Carter from San Francisco. 2 questions. Can you talk a little bit about the indications for treatment, for surgical treatment for the redo cases? We know that radiographical recurrences are commonly found with time. So most surgeons will only operate on symptomatic recurrences, and many surgeons will only operate on severely symptomatic recurrences. So could you comment a little bit about that?
Right.
And then the second question is the Collis rate seems pretty high in this series. A lot of surgeons might argue that that might not be necessary if adequate esophageal mobilization had been performed. And so can you comment a little bit about how you guys mobilize the esophagus and how you decide when you need a Collis?
True. Thank you. So with regards to the Collis Gastroplasty, I forgot to mention that all these patients but 1 of the 34 were actually patients referred to our center from outside hospitals. So as to whether or not they had undergone a previous Collis Gastroplasty, I would have to assume that they did not. But we don't have the operative reports for all of these patients. And again, I think several studies in the recent past have demonstrated that recurrence rates have been demonstrated in patients who have undergone cruroplasty that's been under tension, those who have had inadequate excision of the hernia sac during fundoplications, and those who have had not, as you mentioned, inadequate mobilization of the esophagus. So I agree with you. I think a 24% incidence of Collis Gastroplasty in redo group was high. And I think it only goes to show that perhaps in these patients who were referred to us from other institutions perhaps did not undergo adequate mobilization of the esophagus during their initial operation, which led to the recurrence.
So it was 24% had that in the first operation?
No, it was 24% that had it in the redo during
our
operation.
So you decided to do that?
True.
Okay.
True.
Okay. All right.
And again, the first question.
How did you decide when to operate on a redo patient?
Yeah, so I agree with you. A lot of these patients will have radiographic evidence of recurrent hiatal hernia. Many will not be symptomatic. So it's precisely that, those patients who are symptomatic, and then we go on with further studies. We could get delayed gastric emptying studies, pH studies, endoscopy, upper GIs. And it's really patients who have demonstrated, and commonly will have an elevated Meester score. Most of these patients were symptomatic from reflux disease, recurrent reflux disease. And that's what prompted us to redo their surgeries.
Dr. DeMeester?
Yeah, congratulations on a very nice presented series. It's a controversial issue on whether we get the same results the second time around, dating back to Alex Little's classic paper suggesting that the results with fundoplication decrease at each attempt at doing it. And we have the feeling that maybe with laparoscopic surgery, we're not falling into that same paradigm.
Right.
But my question is, to be really honest about this, you can't exclude anybody that was taken for a reoperation. It looked like you excluded patients that ended up not getting a revisional paraesophageal hernia repair. So if they ended up getting a gastrojejunostomy or esophagojejunostomy because you got in and things were a nightmare, it's not exactly fair to say that the results are the same, because that patient ended up with a completely different operation because you couldn't actually do that, and that's extraordinarily rare to have to do something like that on a first-time operation.
No.
So maybe a fair way is to put everybody that went back in for a second operation, and then see how many times you fall out from not being able to do it.
Completely valid argument.
And then the follow-up question is, did you have patients that had a third or a fourth reoperation in there, and did you see a fall off in results when they got out to those further along the way?
No, excellent observation. And I, again, in the brief 5 minutes or 6 minutes we have to discuss this, I wasn't completely clear in our exclusion criteria. So to answer your question with one answer, both questions with one answer, of the 6 that were excluded, those were patients who had had previous more than at least 2 or 3, in one case had 4 previous repairs, and preoperatively it was decided even before entering the surgery that they were going to get a gastrectomy, that there was no need to attempt a 3rd or a 4th repair. And so in that regard, our purposes were to identify those patients who are undergoing isolated redo, first-time redo, paraesophageal hernia repairs. So excellent observation, and it's a valid point. Most previous studies have looked at that, and they have a conversion rate. You know, they go in planning to do a redo surgery, and they find out that it's just not going to be plausible, and they convert to a Roux-en-Y. Whereas in our case, the reason we excluded them was precisely that reason. Preoperatively, the decision was already made.
A quick question about your questionnaire that you administered. Did they have a numeric sliding scale for severity and frequency?
Right.
And were these symptoms, it looks bad, but were these fairly mild symptoms of bloating, or were they severe, crippling side effects?
So basically, there's a point scale from 1 to 10, and 10 being obviously the worst, and it just said, based on this point scale, where does your bloating fall into? So I guess it's not very specific in terms of it's very subjective, and it's all patient focused.
I also have one last question.
Yeah.
I saw that your gastrostomy tube placement percentage is 30% in the redos. What are your indications for putting in a gastrostomy? It does seem a little high.
It is, and these were patients who had again, as I mentioned earlier, in the preoperative workup of these patients, they all essentially get gastric emptying studies, and these were patients who had severe delayed gastric emptying. And so instead of doing a pyloroplasty, which is an option, we elected to do gastric or G tubes, which are temporary, just to help get them through the postoperative recovery phase.
Thank you very much.
Yeah, thank you.